Welcome back to the Movement Professional Podcast. I'm Dr. Chris Lab. So today we're going to continue on our journey of discussions regarding common misconceptions in the field of health and fitness. Today we're going to tackle low back pain. And specifically, we're going to tackle some misconceptions on one of the most popular podcasts out there, the Huberman Lab Podcast. To be clear, I'm a big fan of this podcast. I've learned a lot from it, but when he started talking about protocols for low back pain, this is more my area of expertise than his. So I was very curious to see what he had to say. And I think there are some things that could be useful for people, but I wanted to just use this as an opportunity to squash the misconceptions that he may have brought up that may confuse some people and actually can be harmful for people getting better. All right, so the first one of these misconceptions, and I've talked about this on other podcasts, is that the idea that pain and damage to the spine are the same thing. All right, so the number one complaint that people will have is not that their spine is damaged, although the two have become synonymous. But the complaint is that they have pain and that pain is limiting their function, it's limiting their quality of life. And we really, really have to get in the habit of separating out these two things. Pain is not damage to the spine. So a good portion of the podcast from Andrew Huberman was to really look at the back pain that he was talking about and giving protocols for back pain, but do it from the lens of here's the anatomy of the spine and here's what might be damaged in the spine that might be leading to your pain. And we really, really have to be able to separate those things out. And that's based on research too, is that a lot of the degenerative findings, which include disc degenerations, and he talked quite a bit about the disc model, which I'll talk a little bit more about, but just any degeneration where there's less space between the joints that happens, it happens in asymptomatic or pain-free individuals just as much as it happens with people who have pain. Especially as people get older, you actually start to see a huge prevalence of people who have these degenerative responses that have no symptoms whatsoever. So I just want to be clear and direct here. I'm going to read from just the abstract of the results of a 2014 paper, a systematic literature review of imaging features of spinal degeneration in asymptomatic populations. So what this says is that in the 33 articles, the reporting images found findings for 3,110 asymptomatic pain-free individuals. So that's a lot. That's a decent population, which makes this a pretty good powered study. The prevalence of disc degeneration, so that would just be something that would be considered a disease if you went and you had back pain and you would be told you have either osteoarthritis or degenerative disc disease. Sometimes it's DJD, degenerative joint disease. But in pain-free individuals, there were 37% of 20-year-olds, and this is 20-year-olds now, were pain-free. In 96% of 80-year-olds, they were pain-free. So 96% of people that are 80 years old. So what this just says in a nutshell, it doesn't mean that it's not related to pain. It just means that as you get older, it is so normal to have these disc degenerative issues that you cannot tie it to the same thing as pain. It is like having wrinkles on the inside is a commonly used analogy. Is as your body gets older, and you can even see it when you're quite young, when you're 20 years old, 37% of individuals had these degenerative changes that happen. So degeneration is not a disease process in itself. It is just simply a process that happens over time, and it does not have to be linked to pain. And if we have that mentality, we're going to be barking up the wrong tree. So that was a big part of what this podcast was predicated on, was basically that we're going to understand the biomechanical damage that can take place in a spine, and that is what causes pain. All right, so we can look even more at disc bulge prevalence increased from 30% of those 20 years of age to 84% of those 80 years and up. So that's, if we're talking about disc bulges specifically, still 84% of those in this study that were 80 years old had no pain and had these disc bulges, and 30% of 20-year-olds had them. And then if we even look at protrusions, which are supposed to be like the full-blown disc comes out, it's got to be putting pressure on a nerve. 29% of 20-year-olds had completely zero pain, and 43% of those 80 years or above had no pain, and that was demonstrated on their MRIs that were looked at. Again, so that doesn't say that when you have pain, that you get these images and they have nothing to do with it. It just says it's not the same thing. So we have to separate those things out. And when we're talking about protocols, which he was talking about, to actually change pain, we cannot be coming at it from that structural model, or we're going to be barking up the wrong tree. So pain is not damage. And then to be a little bit more specific on some of the things he said about the herniated disc model, he was speaking specifically. He didn't use this framing because I don't think he understood or knew where this framing came from. But he was talking about doing lumbar extension, lower back extension type movements, which have helped his back pain in the past. And he connected that to the fact that he was putting his disc back into place, which is a very common model and thought process for what's happening, why somebody can lie on their stomach, arch their back, do different types of what are called lumbar extension exercises, and improve their pain. The problem here is that this model has never really been validated. It's just a theoretical analogy of why you may get better with this exercise or these types of exercises. And again, these type of exercises, I think you referred to them as cobra type exercises that you would see in yoga, but you could think about lying on your belly, pressing up, arching your back, and sometimes that makes your symptoms better. Sometimes it doesn't. You have to go through an assessment to see what moves pain in the right direction, and then ultimately what would be provoking pain too, so we know what direction to go. The point here is that to have the idea that if I'm moving in a certain direction, I'm pushing a disc back in, when that makes you worse, you don't necessarily have a place to go from there. And instead of thinking about this from a structural model, what we can simply do is appreciate that someone's symptom profile, when they come in and they have back pain, when I see a patient and they have back pain, I don't have to think of it as, is it a disc problem? Is it a joint problem? Is it a nerve problem? Because the body doesn't work in isolation that way. It's a pain problem, and pain is separate from those structures at all times. What is really important to know is what pain presentations, if something is made better with certain movement, something is made worse with certain movement, there is some evidence that shows a better prognosis. What he was referring to is Robin McKenzie's model of trying to use directional preference type movements or repeated motions to figure out the direction that helps to either centralize, which moves pain from a leg closer to the center, closer to the back, or peripheralizes, which would be worse, which makes things worse. If it was going from the back and going down the leg, that's peripheralization. So that phenomena has been studied. And if we move pain towards the center, we're doing better for that person. We're doing better for ourselves. But that does not have to be connected to the fact that a disc is going in or out of place. It's just a phenomenon of pain behavior. So we have to appreciate that what we do as physical therapists is we're assessing pain behavior. We're not assessing damage to a joint, and we're not assessing improvement of that so-called damage that might be shown on an MRI. So as I've become a more experienced therapist, I realize that MRIs and images, they mean less and less to me. They're not very useful for what I could do as a therapist. I will explain what I see and what an impression says to a patient if it helps them understand the process. But a lot of times the MRI and the X-ray actually gets in the way of them going through a process that might help them get better, because the imaging is often so bleak that it paints a picture that things cannot get better. And then we have to make up models of why things have gotten better. So we make up models that, well, we pushed a disc back in, even though if we took an MRI after that, there's no reason to think that the disc wouldn't look like it was in the same place it was beforehand. There's no validation of this idea that if pain is changing with movement, that we actually have changed the structure that was indicated to be the diagnosis in the first place. And I think that is so important. That is a huge misconception. So to take this McKenzie discussion a little bit further, Robin McKenzie is a well-known physical therapist from New Zealand that basically his method of assessing low back pain and also other joints in the body is a staple within a physical therapist education. It's one of my first continuing education certifications that I've gone through when I first got out of school. Started in 2007, finished my certification in 2009. And it's very, very useful. the first course I went to, they basically told me, the professor or the instructor told me that the disc model of moving a disc back into place is a theoretical model and it is unnecessary to utilize in order to make this method work. Right. So that's not what's studied. They don't study, did the disc go back in? What they study is what's the behavior of the pain. All right. So the major tenets of this type of thinking is repeated motion testing. If I put somebody on their stomach and I have them repeat extensions, am I moving their pain in the right direction? And again, in the right direction means more central, less peripheral. So more towards the center, and then eventually, hopefully, not there at all. So we're looking for a directional preference through repeated motion testing. So directional preference could mean, did they do better when you flex them? Did they do better when they extend them? Right? And there's reasons they'll do better when you flex them, and there's reasons that they'll do better when you extend them. But the key is that you're following the symptom profile. You're figuring out what's moving the symptom in the right direction. You also get a sense of, does something get better? Does it stay better? Or when you change position, does it get worse? So there's a constant assessment. We don't have to go too deep into what the McKenzie model is, but what he was referencing was basically the McKenzie model, although he didn't realize it was, but he was giving it this herniated disc model, which he referred to as an Oreo cream moving outside of the Oreo cookie. Oftentimes we learned it as the jelly inside the jelly donut, because there's a nucleus basically within the disc that moves outside of the disc, and that's theoretically what's supposed to cause the pain. But again, there's not a lot of evidence that that is true, or that doesn't have to be true for your pain to get better. The major idea here is that as a therapist, when we're doing exercises, we are not thinking about fixing the structure. We are listening to the symptom. We are following what the symptom tells us, and there is some evidence that says it's better when symptoms move more towards the center. So we're trying to find the direction. We're trying to find the appropriate dosage that moves things in the right direction. We can take diagnosis idea a little farther when we talk about things like sciatica, and then we can actually differentiate sciatica from radiculopathy. And I think, again, just to continue on this idea of pain is not damage, but that doesn't mean that damage is not serious and that damage does not exist. So when we hear things like sciatica, again, just a general term that really means that something in the sciatic nerve distribution is involved. So that could be pain down into the butt, could be pain into the butt down into the thigh, pain butt into the thigh all the way down the leg into the foot. The sciatic nerve distribution goes through the butt, to the back of the thigh, branches off, and then eventually goes into the foot. Sciatica is really just a very general term for I got pain in my butt or I got pain in the back of my leg. Where radiculopathy is a very different thing. That would be a nerve root is being impinged upon. And the way that we know that the nerve is being impinged upon is not necessarily because of pain. The more serious and sinister a nerve compression or a nerve irritation is, it has more to do with motor weakness. So we'll actually see the distribution of the nerve to the muscles down into the foot. So you see something called foot drop that often happens. Somebody's gait will change. Weakness becomes more of the issue than pain. Pain often happens really early on if something just gets irritated. So a nerve can get involved in that irritation, but it doesn't have to be because it was impinged upon or it's currently being impinged upon by anything like a disc or the joint is closing down. I think that rarely happens, but I'm not speaking as if I know if it happens or not. I just know it doesn't have to be the case for people to get better and for people to have pain. As soon as we have pain, if we automatically associate it to, okay, my nerve is being impinged upon, then we're going to have issues with how we think about how is that ever going to get better unless we surgically change it. But it does get better. It gets better over time because the inflammatory process works its way through. Oftentimes it gets better just, with time. We see this very, very frequently. But one of the things that we want to separate out, and this is where, again, the difference between pain and injury is bigger injuries to tissues that are more severe tend to be painless, but they will be accompanied by some type of weakness, severe weakness, because there's no connection anymore. If we're looking at severe injuries to nerves, or if we're having nerves that are impinged upon for too long, we actually start to lose the motor function. but it becomes less of a pain. We have a lot of these symptoms that will occur through the body. There are specific pathways that you can really see. There's nerve pathways that you can feel sensation going in through different pathways. There's motor weakness that will go through different pathways. And again, if we start to see some more of these more sinister motor weaknesses and also changes in reflex, bowel and bladder changes, they can be very serious structural damages. But pain is oftentimes not the major indicator there. It has more to do with some of these other neurological things that we have to be really careful with. So again, I just wanted to couple that at. When I say pain is not damage, I don't mean damage is not a thing. I don't mean damage is not serious. I just mean it's not the same thing as pain. And a lot of times the chief complaint that someone has when they talk about low back pain is pain. So we don't want to jump right to the conclusion that there is damage, because it often leads us up the wrong tree. The second misconception that I heard him talk about was just some of the discussion behind stability and bracing, and also breathing. This was subtle, but I think, again, it spoke to his lack of expertise in this area. When we talk about breathing and stability here, he spoke about it as if it was a on-off switch for how you breathe during strength and during high intensity efforts is completely on a different realm as how you would breathe when you're relaxed. One of the ways I like to think about this, though, is that your breath is in a continuum of relaxation and stability, and there's graded pressurization increase that will happen with your breath. To learn how to move your breath and to control your breath, there is quite a bit of carryover for how one can relax, for how one uses that breath when they're trying to be strong or trying to use stability. He definitely spoke as if they were almost opposite in the way that you think about the breath. Is that we still have to understand how to direct our breath where we want to direct it. So whether we're using breath for relaxation or we're using breath for strength, we have to get control of where we direct our breath. To me, it's really not an oppositional type of idea at all, but more of how much do I want to pressurize my breath? How much do I maybe want to hold the pressure that I've created with my breath, depending on the intensity of the task? But the direction of it doesn't need to change that much. And there's really not an oppositional quality to it. It's more of a turning the volume up, turning the volume down quality. So for instance, if I breathe into my lower rib cage and I use my diaphragm a little bit more, I get greater excursion of my diaphragm, I'm going to create a pressure cascade downward into my abdomen, which increases intra-abdominal pressure. If I have control of my breath, I have a choice of how much pressure I want to create there, how much I want to be able to hold that. And then I have a choice of how much I want to pressurize my exhale. Do I want to just let it be a passive exhale and relax and kind of extend that out? Or do I want to pressurize that, hold it, trap some of that intra-abdominal pressure so I can make my cylinder, my midline more stable for a more intense action? I have a choice there, but that choice is within a continuum of pressurization. So it is not two separate things, really. It is really just a matter of how good am I at controlling where I direct the pressure. Sometimes I want to direct it more towards my abdomen. Sometimes I want to direct it more towards my ribs. Sometimes I want it to be abdomen, ribs, chest. The control is the key when it comes to breath. And if we're talking about back pain, a lot of times the control is that we want to be able to breathe lower than we are. If we're breathing up into the neck, if we're doing accessory breathing, which tends to pull the shoulders up when we inhale, we want to direct it down lower. Our diaphragm is lower. It's right on the lower part of the rib cage. We want to be able to create intra-abdominal pressure better. But it really depends on the individual at what moment in time. And the symptom is king or queen. It is the thing that we follow to tell us what's the most useful breath strategy. All right. It's not some type of protocol. And, that will bring me to my last misconception here is the title of the podcast from Dr. Huberman was Protocols to Strengthen and Pain-Proof Your Back. Right away, there's so much wrong with that title for how we need to treat back pain as a society. For one, the idea of back pain is not something to be eradicated. So we can't actually guarantee that we pain-proof our back, nor do we really want to do that. We want to listen to our pain and understand our pain much better. This idea of protocols being what we're striving for, we want something that is easily written down that's good for everybody. It just doesn't exist with back pain or pain in general. We want processes, not protocols. We want to really understand and be educated about a process. So he said many times in the podcast, he was taking information from other experts in the field, people I respect and I've read. And ironically, he did a podcast with one of the people that he was referencing, Dr. Sean Mackey. And Dr. Sean Mackey had so much good, useful information to talk about back pain. I mean, he just really was well educated on it. And he took some of the things that were said by all of these professionals and he put them into a protocol, although in all of the podcasts or all the discussions that he's had with these professionals, they basically warned him not to do that. They didn't want their information to be dwindled down into some type of protocol. And I think this speaks to sometimes an audience that is not in the field is calling for simplicity where simplicity doesn't exist. And if you ask for simplicity, you will often get it. But what you will get is misconceptions and misunderstandings because pain is a process and it's a complex process. The human body is complex. So to make change, we have to be willing to embark in a process. So you don't fix back pain, you change it. And it changes on its own a lot of times. So sometimes we just get the hell out of the way and we let it change on its own. But what happens when we have this pain is damage model is that as soon as we're in pain, we think we're going to damage something more. So we avoid. And that is one of the worst things to do, to allow our pain to change back to its state of not being there or being there in a way that is not affecting us functionally and maybe athletically in the way that we want it to. So we look at change is inevitable. And if we pay more attention to our body, we realize that. And sometimes what happens is the first time we get pain, back pain, we are left with the situation where it's now we notice something because the pain was so great. It forces us to notice something. And ultimately that pain is telling us to change something, but sometimes we can't change it. We're too deep down the rabbit hole or we don't know what to change. In our society, there's so many things that are small stressors to our body that we're just living with all day long, that when our body actually gives us pain and tells us we got to change something, we're not ready to do it. So we seek out some type of other answer that's a simpler answer, that something's broken and it just needs to be fixed. But just there's no evidence that that's true. So we have to be willing to embark on a process of change and be part of controlling our own change. All right. So it's an ongoing process that we're looking to embark on. And it would be great if we experience less pain. But pain is a sensation that we have for a reason. People who don't have pain don't live very long typically. There are diagnoses where you're completely without pain and you end up leading to a shorter life and oftentimes amputations because we don't have that signal to tell us to change something. All right, so we take pain for granted in many ways. And when the pain is great and it's very functional or limiting, we think of the issue as the pain, but actually the problem becomes the things that it's getting in the way of. So if we can be part of a process that improves the things that we're getting in the way of, a lot of times we have a better relationship to pain, and the pain, it tends to die down and maybe even go away for a while. But even when pain goes away, it hasn't been fixed. There's nothing that has been fixed. It's just not there currently. So even when people are in bouts of pain, and this is just, I'm speaking from my experience, nearly 20 years now of dealing with people in pain, if you question it out, you realize that even when you're in an episode of pain, you're not in pain all the time. Pain comes and goes, even when within that episode of pain that you're being treated for. There is a changing of the pain that's happening, even when it's most chronic. And what we have to do is figure out what are the things that we can do that are making you feel better? What can we double down on? And what are the things that you can do that don't affect your pain at all, that don't make it any worse, don't make it any better from a movement standpoint, from a health standpoint, that can move you forward and make you a healthier person? The more chronic the pain becomes, the less it becomes about any specific anatomy or any specific area. It becomes about what is it taking from you? It's taking your function, it's taking your conditioning. And can we gradually get that back in? It's also probably taking many things socially. Can we be aware of those? Can we speak on some of those? So the process that I treat low back pain and I treat any pain is through a biopsychosocial lens. And it's become very evident to me that more and more it's way less about the structure and even the biomechanics than just about giving people a positive experience with movement, but also giving people a positive experience with moving forward in life and not dwelling on the elimination of pain, making friends with pain, to say it in a very cheesy way, to use pain to learn from it. And that's ultimately what we're trying to do as therapists. At least that's what the current research says that I'm certainly seeing and following. And there's a lot of other professionals that are following the same line of thinking. We're trying to learn about pain, and we're trying not to seek out protocols to eradicate it. If somebody is in a search to eradicate pain, usually their prognosis is pretty bleak, unfortunately. So the treatment becomes, in many ways, is how to reframe that thinking and be in a process of improving overall health, where pain is part of what we're working around, we're working with. So I hope that was useful. Again, I don't have any ill will towards the man, and I think the podcast is great. I just thought this was something that I could speak about from my expertise and try to squash some of the misconceptions that may have come, and try to help people move forward a little bit. I know that there's a tendency to seek out protocols, but I don't think we can solve pain through protocols, and I don't think it's something to be solved, but something to be worked with. I'll see you next time.